we'll be talking about peripheral vascular disease, and I'll be going over management, diagnosis and management of intermittent claudications. So let's just review quickly. We'll be reviewing the epidemiology and natural history of peripheral vascular disease, important components of the history and physical exam that need to be taken, non-invasive testing approaches, what does medical therapy consist of, and then when is revascularization indicated and what are the different approaches, and then I have a case study if we have enough time to briefly review as well. So intermittent claudication, what does it really consist of, or what are the symptoms of that? Intermittent claudication can present as fatigue, discomfort, or pain in the leg muscles, such as the calves, during effort due to exercise-induced ischemia. If there's sufficient blood flow so that symptoms are absent at rest, and more often will manifest when there's a higher need for oxygen or blood flow, when symptoms will become more manifest. The most common etiology for claudications is atherosclerosis. Let's review the epidemiology and natural history, and also why this is really important for us to know more about. So as you all know, atherosclerosis is a systemic disease and can affect multiple vascular beds that include, of course, the coronary arteries, and will manifest by angina, infarction, cardiomyopathy, or arrhythmias. In the cerebrovascular circulation, it will manifest as TIA, stroke, and dementia. It can affect the aorta and can lead to aneurysm formation and rupture, or aortic dissection, and also lead to visceral ischemia. There can also be atherosclerosis of the visceral arteries that can lead to renal artery stenosis and renovascular hypertension, renal insufficiency, and mesenteric ischemia. The parietal vasculature can lead to subclavian or involve subclavian stenosis, cerebral and coronary stele. It can also affect the iliac, femoral, and below the knee arteries, leading to stenosis, and then therefore causing claudication. And this is going to be the area we will be focusing on the most today. And this can be complicated by non-healing wounds and limb loss. There's of course an overlap of atherosclerosis, since these beds are not really separate, it's all one single system. You can have an overlap of coronary artery disease, cerebrovascular disease, as well as peripheral artery disease, and often you have patients presenting really with disease in all these different areas. So up to 38% of patients, maybe more, have an overlap of at least 2 vascular beds. So having atherosclerosis in one of these vascular beds is an equivalent for disease in other areas as well. So you can presume that the patient, if you detect it in one area, likely has disease in other vascular beds too. The clinical spectrum of PID, of course, is very wide. Initially, starting off with normal, there's no flow limitation at all, and there will be no symptoms. And as there is increasing flow limitation, you may start with initially just having some fatigue and heaviness. With slowly progressing symptoms to mild, moderate, and progressively worsening to severe claudication. Beyond the symptoms of claudication, when stenosis really gets worse, you can have limb-threatening ischemia and could have rest pain that may be manifested also by poor wound healing, and then impending or overt gangrene. And we see plenty of these patients in the hospital, here at Georgetown, of course. And those with limb-threatening ischemia, the ones that you would see more likely in the hospital, and those with milder symptoms are the ones that you really may be seeing in clinic. And those are the ones we want to detect, screen and detect early on, so that we can intervene before we get to the more severe or limb-threatening ischemia level. The risk factors for PAD are really the same as those that are for other for atherosclerosis and other disease and other vascular beds, and those include smoking, most importantly, and diabetes are the strongest risk factors or predictors for PAD. Other risk factors that are important too, but so to a slightly lesser degree, are hypertension, high cholesterol, hyperhomocystinemia has also been observed in PAD, presence of elevated C-reactive protein. And then the prevalence by age, as expected too, it increases with age. It is much less frequent among patients below the age of 60. But then after the age of 60, there's a pretty linear correlation between the increase of age and the prevalence of peripheral artery disease. It is also more common among men than women in general. And may that be due to, in the past at least, a higher rate of smokers among men than women. But again, this is something that has changed over the decades, of course, as well. And then here, peripheral artery disease and the relative risk of death. The relative risk of PAD and death, you can see here for all causes of mortality. If I move my mouse here, for all cause mortality is 3.1. With cardiovascular disease, 5.9, and coronary heart disease, the relative risk definitely increases. The causes of mortality, so it's very tightly associated with coronary disease, up to 60%. Vascular, 18%. Oops, I didn't do that. I just jumped ahead. Vascular, 18%, and other 10%. So then peripheral artery disease survival by symptomatic status. So normal subjects that have no peripheral artery disease and have no symptoms, of course, the survival is obviously good, as you can see in this light blue graph here on the top. These will be our normal subjects. And if we compare them to patients who have asymptomatic PAD, symptomatic and then severely symptomatic PAD, the survival over the years dramatically decreases as you progress from asymptomatic to symptomatic and then having severely symptomatic peripheral artery disease. The relationship of peripheral artery disease and diabetes has been obviously studied and well described. This is a study among 474 men aged 68 that were followed prospectively for 14 years. And then we can see in the top graph those that had describes the line of patients that had no diabetes with peripheral artery disease. Those who had diabetes but no peripheral artery disease, and you can see, of course, those who had both peripheral artery disease and diabetes, there was a significant difference over time with more presence of peripheral artery disease. And obviously they have worse outcomes as well. So here is a graph that describes the natural history of PAD and the spectrum of disease. This is among a population of patients 50 years and over, up on initial clinical presentation. So about 20 to 50% of patients initially will actually present as patients with asymptomatic peripheral artery disease. A somewhat smaller percentage may present with some type of symptoms that could be more vague symptoms, such as atypical leg pain, or just presenting with typical claudications, up to 10 to 35%. And those that have an initial presentation of critical lymph ischemia is really the smallest percentage. So most patients are really initially diagnosed with either asymptomatic PAD or more often when they have some type of leg symptoms, either as claudication or more atypical symptoms. Now, when we follow these patients over 5 years, their limb morbidity, many of them, the vast majority, with 70 to 80%, will have stable claudications. 10 to 20% will have worsening of symptoms after 5 years. And a small percentage, 5 to 10%, will experience critical lymph ischemia. In terms of cardiovascular morbidity and mortality, a significant amount, 20%, will experience non-fatal cardiovascular events such as MI or stroke. So again, that's why we also consider peripheral artery disease as an equivalent for coronary artery disease, because these patients likely have disease in the coronary arteries and will experience higher cardiovascular morbidity and mortality. Mortality also is very elevated, 10 to 15%, 75% cardiovascular causes, and 25% due to non-cardiovascular causes. Among those patients that have critical lymph ischemia as their first clinical or initial clinical presentation, after following them for 1 year, only 45% will still be alive with 2 limbs. And among the remainder, 30% will have experienced amputation, and 25% will experience mortality. So obviously this patient group has, for obvious reasons, significant worse cardiovascular morbidity and mortality. So it's really important, again, just to stress that we need to understand this section here so we can detect patients early on, diagnose them, and treat them adequately before they progress, and that we prevent these bad outcomes years down the line, which are quite significant. If we look at the prevalence of intermittent claudication by age, similar to the prevalence overall, claudication becomes much more frequent among patients above the age of 50 and 60. So this is really the age group we want to target the most, and ask them questions for screening for peripheral artery disease. And with aging, the incidence pretty significantly increases. This is the classification of symptoms. It's called the Fountain classification. Stage 1 is considered asymptomatic. Stage 2 includes intermittent claudication, and this is subdivided into stage 2A, that is characterized by intermittent claudication after more than 200 meters of pain-free walking. Stage B is characterized by intermittent claudication after less than 200 meters of walking. And then stage 3 is characterized by rest pain, and stage 4 are those that have ischemic ulcers or gangrene. Oops, went one too far. So other measures of determining disease severity include the functional impairment, having a maximum walking speed of 1 to 2 miles per hour, is significant functional impairment. The normal speed is considered 3.3 miles per hour. But of course, I don't think I know any patient who really would be able to tell me what their speed of walking is. But if a patient tells you that they have to take frequent breaks, or I think these measures here are a little bit more specific. So, if you have difficulty walking around your home, and 1/3 of these patients have that, 2/3 have difficulty walking 150 feet or half a block. And this may be equivalent to peak VO2 of patients who have New York Heart Association class 3 heart failure. And if we look at the functionality and quality of life and compare it to other conditions, we can see right over here, the average well adult is over here, having normal functional capacity, being able to walk without limitations for several feet or blocks, without any difficulty. And then if we look at patients with chronic lung disease, they're here at around 38 of this PCS. And a patient who has intermittent claudication is somewhere in the functional capacity between what a patient with chronic lung disease has and a patient with congestive heart failure, in that range. So this is just to demonstrate their functional capacity limitations and quality of life may be similar diminished compared to patients with chronic lung disease or live with congestive heart failure. So it's quite impairing, of course. Let's review the important components to review when we take a patient's history and perform a physical exam. So claudication is analogous to angina pectoris. Intermittent lymph claudication can manifest as muscular discomfort induced by exercise. It's often a discrete threshold of work. It resolves quickly with rest. And then there's also several atypical features that are quite common and may present up to about half of the patients that have claudications. And it could be just something as vague as experiencing fatigue in their legs, calf, thighs, or even glutes, as well as heaviness or dysesthesias. Some of the key questions we should ask, it doesn't really take much time during an exam, should include, do you have pain in the muscles of your legs when you walk? So this is a very simple screening question that may open up to a lot of information the patient can give us about potential peripheral artery disease. The physical exam includes checking pulses. You want to check the femoral, popliteal, and ankle pulses. You want to listen to bruits. And then you also look for trophic skin and hair changes. Since these patients have poor circulation, you often find a very thin and shiny skin, and often there is in those areas they will also experience hair loss. Those are the typical signs of peripheral artery disease. Then there's some signs of impending critical lymph ischemia, important to not miss, of course, dependent rubor, ulcers, or tissue necrosis. Often it's accompanied by pain, but doesn't always have to. But if you see, of course, red, swollen, changes of the skin, and with diminished pulses, it's something you should be concerned of course. Now, in terms of non-invasive testing, let's review quickly the arterial anatomy of the lower extremities. So the aorta bifurcates into the common iliac arteries, and then further bifurcates into the external iliac artery and the internal iliac artery, which will go to the pelvic organs. So the external iliac arteries will descend down the legs and then turn into the superficial femoral artery, the SFA, then at the level of the knees, approximately into the popliteal, and then will further branch into the anterior tibial artery, the peroneal artery, and posterior tibial artery. The anterior tibial artery will turn into the dorsalis pedis, dorsalis pedal artery in both legs. So a very simple and effective screening method to evaluate for peripheral arteries are the arterial brachial index, which can be performed in any office as long as you really have a blood pressure cuff. I think most of the time, most offices, we refer our patients to the vascular office for determination of evaluation of ABIs, but it could be done in any physician's office, really. And it's really based on the principle of the ratio of the ankle pressures over arm pressures. So you take the blood pressure, and let's say for the right side and the right arm, you measure the systolic pressure. And then for the lower extremities, most often a Doppler is used for that. So that may be the limitation for most physician offices. If you don't have a Doppler available, it may be somewhat more difficult to determine. But if you did, you would use a Doppler at the different vascular beds, inflate your cuff, and then see at what point the Doppler disappears to determine your systolic pressure. And then you simply create this ratio of the right ankle pressure over the arm pressure. And that will determine your ankle brachial index. A normal index is greater than 1.3, or anything that's greater than 1 is really normal. The 0.9 to 1 is somewhat borderline and could be equivocal, but anything that's below 0.9 is really abnormal and should raise concerns and be further evaluated, of course. So the ankle brachial index is a very simple, painless, accurate, and highly reproducible exam. It's clinically really useful because it helps us identify patients with peripheral artery disease. And it's a major indicator for premature MI, cardiovascular accidents, and mortality. Since we discussed earlier that presence of peripheral artery disease is an equivalent for coronary artery disease or atherosclerotic disease and other vascular beds as well. Indications for any patient with suspicion of peripheral artery disease, any patient at risk of PAD, that include those patients greater than 50 with a history of diabetes or tobacco use, which are the two main determinants or risk factors for PAD. So it's age, diabetes, and tobacco use. Or any patient above the age of 70, regardless of their risk factors. So who should be screened with ABI? According to the American Diabetes Association back in 2013, the recommendation has been to screen any diabetic over the age of 50 or any diabetic under the age of 50 with other risk factors. According to the USPS task force, evidence that ABI can detect asymptomatic PAD, and but there's little evidence of benefit beyond treatment based upon cardiovascular risk assessment. And they gave it a D recommendation against routine screening, which is why it's maybe not been adopted to really screen anybody above the age of 70. So I think you can use your clinical judgment based on your risk factors, age, when you think this may be appropriate. If you have a 70-year-old who's really very athletic and able to walk and has absolutely no symptoms and with great exercise tolerance, is probably not the right test to do just blanket-wise based on these screening statements. So you can also do segmental pressures in ABIs based on different segmental or vascular beds. It's the same principle. You take the brachial systolic pressure and then take the systolic pressure of the specific artery that you would like to test, and can determine therefore ABIs by different segments. So if we, in this example here, if you took the left arm, you've got the femoral or iliac arteries, and then if we go down here to the tibial arteries, 80, if you do the ratio of 80 over 142, you would get a very reduced index of 0.6. And in this patient, similarly, as you go further down in the arterial beds, the ratio of your lower extremity systolic pressures over the brachial artery systolic pressure will result in a very reduced ankle brachial index, which suggesting that there is significant stenotic peripheral artery disease. That is how this would look like. Of course, there's other non-invasive testing, and those include exercise ABI, which are the same ABIs, just that you would repeat the ABIs at different levels of physical exertion and see if you have inducible ischemia. And this is very analogous to what we do with cardiac stress testing. With angina, often patients don't experience angina at rest, since there may be sufficient blood flow and oxygen supply to the heart muscle, and therefore don't experience angina. But the moment you have these patients walk or have the heart undergo stress and the oxygen demand increases, you may start inducing ischemia. And this is similar for exercise ABIs as well. Then you can also obtain continuous wave Doppler, and based on the wave Doppler pattern, you can find stenosis. Then duplex ultrasound, there's pulse volume recordings, MR angiography, and CT angiography. But of course, all these testing is much more involved and complicated compared to a simple ABI as a screening method. So here's an algorithm for diagnosis of peripheral artery disease. So diagnostic testing, if you suspect peripheral artery disease, of course, initially you need to get a good history and physical exam. And if that is suggestive of PAD without resting pain, or if there's non-healing wound or gangrene, then you would proceed with ABIs. And depending on the symptoms, you can add on segmental limb pressures and waveforms. So if you have non-compressible arteries with an ABI greater than 1.4, you can look for alternative diagnosis or lifestyle. You do further testing and see if there is potentially other disease. If there's really more significant, with non-compressible arteries, and if there's significant disease, then we will go further down this flow chart. So I'm going to skip this right now to go back to this section, as we're going to end up in this area anyway. So if you have a normal ABI or borderline ABI, then you may look for exertional non-joint related leg symptoms. If the patient has that, then you would proceed to exercise ABI. If it's abnormal, again, you would do lifestyle limiting. If they have lifestyle limiting claudications, you, of course, implement guideline-directed medical therapy, and you can consider revascularization. If these patients have non-joint related leg symptoms, if they do not have that, then you look for alternative diagnoses. For patients who have abnormal ABIs, you can automatically proceed to therapy, of course, and consider revascularization, depending on if therapy worked or didn't work. Or you can also already decide to do exercise ABI early on to help you in your decision making on just medical therapy versus the need of intervention. So if you have lifestyle limiting claudication despite maximized guideline-directed medical therapy, then you could proceed with either anatomic assessment by using duplex ultrasound, CTA, or MRA, or your other options also anatomic assessment by invasive angiography. But at this point, it's probably worthwhile sending the patient to a vascular specialist to have that further evaluated. If their symptoms are not lifestyle limiting, then you will just continue with medical therapy. This is a class 1 indication. You should not perform invasive or non-invasive anatomic assessment for asymptomatic patients, since there's really no benefit and you're more likely to cause harm actually than benefit. So what does medical and lifestyle therapy consist of? The treatment goals in peripheral artery disease are to limit progression of atherosclerosis, reduce the risk of cardiovascular events, relieve symptoms of claudication, and of course improve functional capacity and quality of life. Non-pharmacological therapy of peripheral artery disease consists first and most importantly of tobacco cessation, which is one of the main risk factors, and it's going to be hard to treat a patient who doesn't even quit smoking. And unfortunately, we do see a lot of patients who have significant severe peripheral artery disease and are still smoking, so that's very difficult to treat. And then, of course, exercise training, modify any other risk factors, most importantly diabetes, which after smoking is the second most important risk factor for PAD, and then also podiatric care. So how important is smoking cessation in peripheral artery disease? So 5-year follow-up of patients with peripheral artery disease but continue to smoke. If you look at these patients, there's been a 27% risk or incidence of death after 5 years. For among those who stopped, that risk for death after 5 years is reduced to only 12%. So that's how important it is, of course. We're also able to reduce major amputations among those patients who stop compared to don't stop. And then patients who continue to smoke experience a 31% of amputation or surgery, which was significantly reduced among those patients who quit smoking. Sometimes showing these numbers to a patient that smokes may be really beneficial for them to understand how important quitting smoking is. In terms of smoking cessation and endovascular revascularization, in a study of 739 patients who underwent endovascular revascularization, 28% were active smokers and 30% subsequently quit. The 5-year mortality rates were 14% versus 31% among those who quit. So this is just similar to the same data I just presented. And those who also quit had a better amputation-free survival, which was 80 versus 60%. So there are multiple studies that really show that patients who quit smoking, even if they had been smokers for many years, they do reduce the risk for morbidity and mortality significantly upon quitting smoking. So supervised exercise training is also something really important, and there's good evidence that this really works. So structured exercise program that takes place in a hospital or outpatient facility, such as a physical therapy rehab facility, in which intermittent walking exercise is used as a treatment modality. The program can be standalone or can be made available within a cardiac rehab program. It should be directly supervised by qualified healthcare providers, and training is performed for a minimum of 30 to 45 minutes per session. in sessions performed at least 3 times per week for a minimum of 12 weeks. Patients may not initially achieve these targets, and a treatment goal is to progress to these levels over time. Training involves intermittent bouts of walking to moderate to maximum claudication, alternating with periods of rest. Warm-up and cool-down periods precede and follow each session of walking. So these are the official recommendation of how a supervised exercise program should look like. And they do, of course, exist. The problem is that it's still often not reimbursed. That may be a limitation for patients really participating in a supervised program. So if we look here at initial claudication distance, compared to patients who underwent exercise rehab compared to controls, at baseline, of course, the control were walking a little bit better, but nevertheless, the patients who participated in the exercise rehab program had a significant increase in their ability to walk, in the distance that they were able to walk at the end of the program. So it was statistically significant, while the control group who didn't participate in the program did not see a significant increase in their ability in their walking distance. Similarly to the peak walking distance here, in the those that had participated in the exercise rehab saw significant improvement compared to patients who didn't participate in a supervised exercise program. So the pros and cons are that it's of course effective. It's a compliance challenge, but it's also not reimbursed. And that's probably one of the major hurdles for us to getting patients into supervised exercise program. The greatest benefit are older patients. If you had longer durations of symptoms, poorer baseline hemodynamics, and the optimal implementation also is really important. Ideally, patients have direct supervision. They should exercise to near maximum pain as training endpoint. So if they do it alone, patients may often not push themselves to this near maximum pain training. And using walking as an exercise modality, they should have at least 3 sessions per week, and it should span over at least 6 months. So those are the pros and cons of this. Oops, I went back. And since many patients aren't able to participate in a supervised exercise program, they can also do home-based exercise programs, and that's what we often end up recommending to patients. So we have to provide education and behavioral interventions. There are new devices now that monitor duration, intensity of exercise sessions. We can recommend patients to use the activity trackers. And there are randomized trials that show more than 80% adherence with results similar to supervised exercise. So we can use technology now, mobile technology, to help our patients achieve these goals, even if they can't, if the insurance doesn't cover a supervised exercise program. So here are a few sample home-based programs. Frequency about 3 to 5 days per week. Modality can be treadmill, but it can also be adapted for walking outside. And you begin at 2 miles per hour and a grade of 0, so you walk at flat level. Try not to hold onto the treadmill. Use the side for balance only, or ideally you don't use anything to walk. Stop the treadmill completely when pain is 3 to 4 on the claudication discomfort scale. And when the discomfort has ceased, resume exercise at the same intensity, and then repeat the same rest exercise cycles. Progress to a higher workload when you can walk for 8 minutes without having to stop for leg symptoms. And then increase the speed. Once you've reached it, you increase the speed by 0 to 0.2 miles per hour each time you can walk for 8 minutes. Once you're able to walk at 3.4 miles per hour or reach speed at which you can no longer keep up, begin increasing the grade by 1%. So these are very clear instructions of how to gradually increase their exercise capacity once they reach certain goals or milestones. So the total exercise period, including rest periods, should equal 45 minutes per day. A few tips for success: do not continue walking past 3 to 4 on your claudication pain discomfort scale. This way the pain discomfort should go away in 2 to 5 minutes. If you walk until you're in severe pain, you will build up lactic acid in your muscles, and it will take much longer for the pain to go away. When at 3 to 4 on the pain discomfort scale, stop walking completely. Do not slow down, but stop and stand on the treadmill until the discomfort is gone. This will work if you do it, of course. Will not only improve your walking performance, decrease your discomfort, and improve your quality of life. This type of program is also beneficial for your heart, blood pressure, and lipid levels. So this is a very good guideline or instructions to give to patients who are going to do home-based exercise programs. Medical therapy in PAD should address outcomes and prevent major cardiovascular events. So patients with peripheral artery disease who are undertreated versus CAD patients shows that they are less than 75% are on statins when it's really indicated, and only around a third are on aspirin. So we are undertreating our patients significantly and need to be more aware and cognizant about that. So if we look at GDMT and outcomes among these patients, if the red line, the red graph shows those patients who are on less than 4 metrics of guideline therapy versus those who are more optimized on guideline therapies. And you can see, of course, over time, the major adverse cardiovascular events among those who have been better optimized on guideline therapies have much improved and lower cardiovascular events compared to those who haven't. Similar with lymph events, it's very similar. If you are not optimized, you have a much higher incidence of adverse lymph events compared to those patients who are being optimized on guideline therapies. So what entails pharmacological therapy for atherosclerosis is somewhat similar to coronary artery disease. Based on prior studies such as the Carvery study, aspirin or Plavix are both can be indicated and used for PAD. Some patients have aspirin allergies, so Plavix is an acceptable choice, of course. Aggressive lipid lowering is really important here with statin therapy. And then current guidelines recommend moderate to high intensity statin therapy. I would treat these patients similar to coronary artery disease with a goal LDL of 70 or lower, or and/or use high intensity statin levels, medication strength. Antihypertensive therapy is really important too. You can consider ACE inhibition. They've shown a reduction in events in the HOPE trial, but this is somewhat mixed results for symptoms. But again, blood pressure is one of those other things that has been shown in multiple trials that people are really not adequately controlled, and often in studies shown that many patients, up to 40–50% among population of hypertensive patients, that they are not really reaching blood pressure goals as recommended by the guidelines. So we need to aggressively lower cholesterol, blood pressure, and treat with antiplatelets. There are 2 remarkable trials that came out last year that I wanted to mention. One is the COMPASS trial that evaluated aspirin monotherapy versus combination of rivaroxaban in combination with aspirin. And those were randomized controlled trials, and they showed significant reduction in stroke and cardiovascular mortality, whereas severe bleeding was less frequent with less clinical impact. So this was particularly favorable in high-risk subgroups and those with multiple risk characteristics. So the COMPASS trial makes an argument for actually not using aspirin alone, but combining it with a low-dose rivaroxaban twice daily in patients that, of course, are low bleeding risk. If you have a patient that may be too high bleeding risk, you may not want to do that, of course. Similarly, there was the Voyager peripheral artery disease trial that also was published last year in the New England Journal of Medicine. This trial similarly was a double-blind placebo-controlled trial of patients who had peripheral artery disease and underwent low extremity revascularization, and they were randomized to rivaroxaban or placebo. All of them had a background therapy of 100 milligrams of aspirin daily. And this trial, similar to the COMPASS trial, showed that rivaroxaban, a dose of 2.5 milligrams twice daily plus aspirin, was associated with a significant lower incidence of the composite outcome of acute lymph ischemia, major amputation for vascular causes, myocardial infarction, ischemic stroke, or death from cardiovascular causes than aspirin alone. So there are 2 large plus double-blind or randomized controlled trials that really made an argument for low-dose DOAC with aspirin for these patients with PAD or PAD post-revascularization. So should always be considered and keep that in the back of your mind when you see these patients. In terms of statin therapy, that's of course super important. The REACH registry looked at 5,800 patients that had symptomatic PAD and were followed for 4 years, and those on statins had lower combined Lymph outcome. That was statistically significant, 22 versus 26%. They also had a similar relative reduction in MACE. Let's review the role of invasive testing in mechanical revascularization. So you can perform diagnostic angiography, and that is recommended only when revascularization is considered. There's a small risk of complications that can be due to the vascular access site or contrast nephropathy, since we use iodinated contrast for that. Revascularization is really reserved for those with severe lifestyle limiting symptoms. Often those are patients who have disabling symptoms with inadequate response to exercise, and where we expect that intervention will result in improvement. They have to be carefully selected based on the anatomic characteristics. Claudication is generally not a surgical disease and should be treated medically. And there's mixed evidence that revascularization prevents lymph threat, analogous to PCI for stable angina. In the past, many years ago, before the FREEDOM trial and other trials, in cardiology, many patients were just revascular because it seemed logical that if you have a blockage, you should open it. But then we learned over time that medical therapy was just as good as stents. And this is similar for peripheral vascular interventions. If it's not a major problem, medical therapy is probably superior compared to stents, unless you have a compelling reason, such as critical lymph ischemia or other, to pursue revascularization. Then there are endovascular treatments for the iliac disease. Of course, long-term patency approaches those to surgery, more than 70 to 80%. For femoral popliteal disease, there's variable patency depending upon the length and severity of the disease. Drug-coated balloons and drug-eluting stents may be promising and may improve the outcomes in this. And then for tibial disease, it's most commonly involved in diabetic patients, and it's usually only indicated for limb salvage and not for claudications again. It really, again, comes back down to medical therapy and lifestyle changes. Here's a case example of a 53-year-old female patient who had a history of hypertension, hyperlipidemia, and is a cigarette smoker. So again, the classic risk factors for PAD. On physical exam, we notice that there's no left femoral and ankle pulses noted. The patient describes disabling claudication more on the left side compared to the right. She's unable to complete housework and had minimal response with unsupervised exercise. So she tried the home-based exercise, but hasn't really experienced any improvement. So if you look at the segmental pressures in this patient, she complained more of left-sided symptoms compared to the right. So if you look down here, the segmental limb pressures, brachial systolic pressure on the right was 117, and not obtainable on the lower extremities. And then in the left, we have a brachial systolic pressure of 118, and then in the lower extremity systolic pressures gradually decrease. You can see here, and the ratio is quite significant at 0.7, and as we go further down on the limb, really steadily decreases. So we suspect or expect significant disease here. While on the right, we've not, let's look at what our further evaluation shows in this patient. So she actually underwent exercise treadmill testing to further define this more. As you can see here, this is rest. The brachial was 118, and then we had the right ankle was 135 and the left ankle 85. So the right was a normal ABI at rest, and the left was diminished, as we had seen earlier. And then as we progress with exercise, we check it at 1, 2, 3, 4, 5 minutes progressively. The index for the left lower extremity steadily decreases with exercise. So this is similar to exercise-induced ischemia or exercise-induced angina on a stress test. So the patient then underwent angiogram, and so this would be the aorta. And then we can see the vessels here, the femoral arteries and the iliac arteries. Here you see disruption. There's basically lack of the artery. There's just a gap, and you just see a lot of collaterals, and then you see the flow reconstitute further down. There is a stenosis here, which is maybe a 40–50%, and the patient again didn't really describe symptoms on the right side so much. So in this patient, she did undergo peripheral vascular intervention and had stents placed in the right artery as well as on the left side. You can see the balloons being inflated here, and you can see the stents on both sides. And then post-stent placement, you see really good blood flow again in the whole iliac femoral artery, femoral iliac artery system on the right as well as on the left. And then post-stenting again, you see this is Doppler flow, improved or normal blood flow in both extremities. And you can also, as you see here, the ABI index has normalized now with higher systolic pressures in both lower limbs. So in summary, peripheral artery disease is a marker of elevated cardiovascular risk, and smoking and diabetes confer the highest risk for developing intermittent claudication or peripheral artery disease. Ask patients about muscle pain with walking, and symptoms and exam findings should drive testing. PAD patients are medically undertreated and also underdetected because we don't really, in general, don't do a good enough job to really screen our patients for PAD. So we need to screen more, detect it more, and treat them better. So again, in summary, the management includes aggressive treatment of underlying atherosclerosis, just as if similar to what a patient should be treated with post-heart attack. That includes smoking cessation, aggressive lipid lowering, antiplatelet drugs, and as I mentioned earlier, based on these new trials last year, we should consider adding low-dose rivaroxaban to our antiplatelets and select patients that are not at high bleeding risk. Consider adding ACE inhibitors and aggressive antihypertensive therapy. We do need to recommend exercise walking programs or regimens to our patients, ideally if possible supervised training, which provides substantial benefit, but it's not reimbursed, so patients may not be able to attain it. But if not, they can do home exercise programs that involves really repetitive walking to pain, with intermittent resting periods, 45 minutes a day on at least 3 days a week, on at least 3 days per week. And pharmacological therapy can also include cilostazol in carefully selected patients, but has shown modest benefits. Really, the mainstay is still aspirin, Plavix, low-dose rivaroxaban. Now, for patients with aortoiliac disease, consider endovascular treatment if anatomy is appropriate. And again, this is most often done by vascular specialists. There are, of course, vascular surgery, but some cardiologists also specialize in peripheral vascular interventions. And for femoral popliteal disease, similarly, you can consider endovascular treatment if you have disabling symptoms and appropriate anatomy. Tibial disease is best managed medically, and it's because those arteries are really small and haven't shown such good results with this.